I thought I would just remind ourselves why we want to treat this disease. So this is survival in a general population here in the black lines. These are acromegaly patients with diabetes, and these are acromegaly patients with cardiac disease. And so we can see that their life expectancy is considerably shortened by an average of 10 years. And clearly we want to reverse that, which we know we can by normalizing their growth hormone and IGF-1. And this is the current sort of definition of how we define disease control in acromegaly. So if the growth hormone following a 75-gram glucose challenge is less than 1 nanogram per ml, they have an age and sex normalized IGF-1, and there's no clinical evidence of disease activity, then we call these patients controlled. Whereas if they do not suppress growth hormone with glucose, they have elevated IGF-1 and clinical evidence of disease activity, then these are poorly controlled patients. And then we have various combinations in between. And as was pointed out by Dr. Van Hurley, we do see patients who have elevated IGF-1 but normal response to glucose, and vice versa. We have some patients who have relatively normal IGF-1s but abnormal responses of growth hormone to a glucose challenge. So we need to do both these tests to characterize these patients. So this has been the sort of paradigm in the management of acromegaly, and this is an example. We've seen some similar ones today, and you can see in this preoperative MR there's a large pituitary tumor extending superiorly and laterally with compression of the optic chiasm, and I think in most pituitary centers we would recommend this patient have pituitary surgery. So here the patient has had a standard pituitary surgery, and the postoperative MRI shows that the chiasm has been nicely decompressed and a large amount of the tumor has been resected. However, you can see there's still residual tumor here in the right cavernous sinus, and this is reflected in the postoperative endocrine evaluation, which shows a persistently elevated IGF-1 and also a failure of growth hormone to suppress. And this has been a very common finding. Now, as Dr. Bergsteiner said, we're moving towards an era when a lot of surgery is going to be done endoscopically, and the benefits of that are still being debated. This is one of our patients, and here we have a preoperative MR, not very dissimilar to the prior one. The IGF-1, as you can see, is very elevated, and the growth hormone is also very elevated and does not suppress even close to what would be considered normal. So this is the postoperative image. There is no visible residual tumor here. The problem, however, in my mind, is that the IGF-1 is still a bit elevated, although much improved from before, and the growth hormone, although it is much better than the preoperative pattern, still is not normal and does not suppress with glucose challenge, indicating that there must be some residual disease. So if we look back at the typical cure rates, and this is based on expert surgeons who do at least 50, maybe 100 or more surgeries a year for microadenomas, and it's just a little off the screen there, but the success rate is between 59 and 85%. With macroadenomas, however, and typically acromegalic tumors, growth hormone screening tumors are microadenomas 90% of the time, the success rates are between 22 and 65%. And clearly it depends a lot on tumor site, the extent of the tumor, etc. Now, it's not yet clear if the newer endoscopic approaches will offer improvements over speculum-based surgeries. Some early publications suggest that it certainly will be better, but as we see in this case here, even when we have, to all intentional purposes, resected all of the tumor, we still have residual biochemical disease. So this has led some people in our field in endocrinology to ask the question, could we use medical therapy as a primary treatment in acromegaly? And if we look here at a series of studies beginning in the late 1980s, you'll see that using somatostatin receptor analogs, that these drugs offer very good control of growth hormone and IGF-1 in up to 75% of patients. But not only that, more recently it's become clear that these drugs can actually shrink tumor, and this is one very good example from a publication some 7 years ago by John Bevan from Cardiff and Wales. And here we see a typical growth hormone secreting macroadenoma at baseline, and then this is 24 weeks later when the patient has been treated with somatostatin ligands, and you can see that this tumor has shrunk dramatically. It's not very different to what we have come to expect with D2 agonists. And when we look at a larger number of patients in this study in the UK called the primary Octreotide study, you can see that these compounds normalized IGF-1 in about 50% of patients. They controlled growth hormone in about 80% of patients, but they also caused significant shrinkage, and this here is greater than 30% of the original tumor size in 70+% of patients. And there have actually now been a large number of studies using various somatostatin receptor ligands, and if you kind of glance over here, you can see that significant shrinkage has occurred in a significant number of patients. I mean, it does range quite a lot. The definitions of shrinkage varied, sometimes greater than 30%, sometimes people took diameters, but the bottom line is that we now have 14 studies with almost 500 patients, and about 40% of these patients had significant tumor shrinkage. So it's sort of got to the point now certainly in endocrinology, where in a selected group of patients, whereas before we would have recommended pituitary surgery, given that even when the surgical techniques are really at the top of their game and no visible tumor is left behind, we still have biochemical disease activity. Therefore, the patient is going to go on to drugs anyway. And so I don't think it's unexpected that some leaders in the field are proposing that perhaps some of these patients should be treated with medical therapy up front.
What's the long-term, I guess, complications of being on a somatostatin, on those types of agents?
None that we know of. There are some side effects, particularly GI, motility alterations. There's a risk of cholelithiasis, which is probably the most severe. Occasional patients get colonic stasis. I mean, I've seen one example of that in a fairly broad experience of using these agents, but they are relatively innocuous in terms of treatment. They do have a cost. They're not inexpensive drugs, but given the challenges that we have currently with getting full disease remission with surgery, even with these newer techniques, which are clearly better, one has to ask the question, are there a group of patients who should be treated medically from the start?
Is there a dose relationship with the size of the tumor? You would dose the drug differently depending on how big the tumor is?
Not really. Generally, we start with a mid-range concentration of the agents that are available, and then based on biochemical markers and imaging studies, that can be increased or decreased.
Is that lifelong?
Yes, it would be, we believe.
But these are drugs that are given at a monthly, or if you're lucky, every 6 or even 8 week intervals, and can be given at home by the patient. They don't have to come in.
Well, so you asked what our feeling is that this is why I have every patient see you, because I think every patient deserves to hear both sides and to make a decision for themselves. For some patients, surgery offers that chance of cure, and you don't have to be on medications for the rest of your life. And for some patients, that's an important decision to make. And for others, they want to stay away from the knife, and I don't blame them. And there's, I think, very little downside to pre-treating them with medication